The next heading, second last one, is research. What's your opinion on the use of N-acetylcysteine in Fontan-induced cirrhosis, or has there been any research? So N-acetylcysteine, the real validated setting is in paracetamol overdose. So it's our antidote for acute liver failure, or our treatment for acute liver failure from paracetamol overdose. And that's because it repletes the enzyme that breaks down paracetamol in the liver, and we give it by intravenous infusion. So it works very well in that setting. It's been looked at in other forms of liver disease, particularly things like what we call hypoxic hepatitis. So when the liver's starved of blood, usually due to low blood pressure, or if you're very sick in ICU, for example. And you know, the jury's out on whether it does anything there, but it's a very innocuous drug. So if the liver's suffered an acute injury, we'll often recommend that, some centres may recommend that you have a bit of N-acetylcysteine. Certainly, I think there's oral preparations, but they've got no evidence, and I wouldn't use them. And there's certainly no specific evidence in the Fontan circulation that N-acetylcysteine helps. The next question is, has the impact of Fontan cirrhosis on vitamin D metabolism been investigated, or should we routinely be supplementing or testing for deficiency of vitamin D? Yes, people should be tested for vitamin D deficiency. That's not just specific to Fontan patients, but I do understand that the prevalence of vitamin D deficiency is higher. As I mentioned before, that's related maybe to sun exposure, but also to the kidney. So there can be back pressure on the kidneys in Fontan circulation, and the production of the hormone that activates vitamin D might be reduced. Secondly, if you've got advanced liver disease, vitamin D deficiency is very, very common, and that's again due to to several hormonal mechanisms. I think the parathyroid glands have also been implicated in Fontan associated vitamin D deficiency. So yes, you should be having it checked regularly, and it should be supplemented. You can't really overdose on vitamin D either, so I wouldn't be afraid if the doctor, your GP or specialist recommends a big dose like 25,000 units to get the level up. But it's very important for bone health that stays up. Okay, someone's quoted an article, Fontan liver disease, review of an emerging epidemic and management options. In this article, the authors mentioned that some data from previous studies indicates that there may be some damage done to the liver prior to Fontan in some single ventricle patients. Can anything be done to protect the liver from damage early on in a patient's life, or should we be checking the liver of single ventricle patients prior to Fontan? Again, most people will have their operation when they're young children. The process of chronic liver disease takes several years, and so it's very unlikely that they'll have significant enough liver disease that will cause or will prevent more cardiothoracic operations. If there's a second liver problem, so children are born with liver conditions, they might have there's a whole host of pediatric liver conditions that might influence whether a Fontan procedure or cardiothoracic procedures are safe or not. But they should be tested for individually, and usually they're gauged by the liver function tests and imaging findings at the time. So generally the livers are checked of people undergoing, or anyone, a child or an adult undergoing cardiothoracic surgery. But I don't think a liver biopsy, for example, would be indicated unless there's a significant liver disease that's being investigated. What are the latest statistics of liver implications from Fontan circulation, with particular reference to those with the AP Fontan? Again, it's really hard to specify the type of Fontan. I think I've mentioned several times now that it's the degree of liver fibrosis. It's assumed that everyone will develop some form of liver fibrosis, from very mild or advanced fibrosis in the long term, the longer time goes out. Whether this has an impact on liver function is very individual. Certainly those early stages of fibrosis won't. Cirrhosis, it's only a very, very, very late stage of disease where you might see problems with the way the liver is functioning, and that's not very common. Again, if cirrhosis has developed or been proven, the risk is whether there's potential for liver cancer developing, and that should be screened for regularly by 6-monthly ultrasounds, or if there's nodules, then going on to imaging with either CT or MRI 6 to 12 monthly. And also a blood test we'd recommend as well. Okay, so the next one is, from the surveillance that has been carried out so far on those of us with cirrhosis, is there much progression or is it fairly stable, slow going? That was mentioned in the Fontan education that cirrhosis may have a result of the surgery not ongoing. Can you clarify this? I think again, it's a similar sort of question. It generally is ongoing. It is a slow process. And if it is faster than a slow process, then there's probably a second thing going on that needs to be investigated and looked at. But as far as we're aware, it's a slow process, takes many years, many decades in some people. And that's purely dependent on the health of your Fontan overall. Okay, the last section is liver transplantation. So how common is a liver transplant internationally, and how do the numbers compare across Australia and New Zealand? So liver transplantation is probably one of the modern success stories in medicine. It started off with very dire outcomes in 40 or 50 years ago, but the last 20 years have seen revolutionary change. Of the survival outcomes are amazing. So particularly in the last 5 years, generally over 90% 5-year survival in most programs. So in Australia and New Zealand, we've done over 6,500 liver transplants since the national registry, binational registry started 30 years ago. Last year we did 368, and that's a reasonable number. The highest volume centre that we have is, or the highest volume centres we have are in Sydney and Melbourne, and we classify our centres as being moderate volume overall. So we roughly do between just over 100 adult and paediatric transplants, between 100 and 130 each in those settings. A large volume centre would be somewhere doing over 200, and that they exist in the States or in Europe. In the US, they do about 8,000 liver transplants a year, and the European Transplant Registry at last count had about over 150,000 liver transplant recipients on the books. So it's a relatively common transplant to have. It's an excellent transplant as far as the outcomes go. And liver transplantation has become a lot more routine, and we're doing a lot more complicated transplant procedures, people with lots of different conditions, as well as combined procedures more often now because of the success that's happened over the last 3 decades. The second question here is, do you have any details on the prevalence of Fontan patients in the transplant figures? Well, that's a very hard question to answer. So certainly locally, in Australia, there hasn't been any Fontan-associated liver transplants that I've been aware of, or a quick straw poll of my colleagues, no one could recall one. There has been a case done in New Zealand, but not here in Australia as yet. That said, there has been combined heart and liver transplants done for other indications. There's been probably about 10 done across Australia and New Zealand in the last 20 years. The majority of those have happened in Queensland as part of a heart, lung and liver transplant program, and the major indication has been cystic fibrosis. And in New South Wales, there hasn't been a heart liver as yet, but we do heart lung transplant fairly regularly, and we've done several of the units across Australia have done liver transplant with the combined cardiac operation. So there's good, reasonable experience there. When it comes to the US, they've done about 250 patients with heart liver transplants at the last review. And the outcomes for these patients have been as good as heart transplant alone. And one study suggests they might be even better. But again, this is a very selected group of patients who've undergone extensive workup. And what those registry studies don't tell you is who didn't go through the transplant process because they were too unwell, their disease was too complicated. So it's really a very specialized area. And if those options have been mentioned, then speaking to your transplant physicians, as well as your regular cardiologists and gastroenterologists, is certainly worthwhile to update you on your specific situation. When might someone be recommended for a liver transplant, and what are the outcomes for transplants in the last 10 years? So I think I answered that second part of the question. Liver transplant that is probably the most successful solid organ transplant. The liver is fantastic in terms, I'm sounding like Donald Trump, but the liver is great in the post-transplant setting because it's quite tolerant, meaning that you can use a lot less immunosuppression than in other organs such as the kidney or the lung. And so the outcomes are very good, particularly after the first year. But the 10-year survival is somewhere around 80% on average, and that's all comers, so it's different for different populations. And when might someone be recommended for liver transplant? So the main thing is liver failure. So I mentioned that liver failure refers to the actual inability of the liver to perform its functions, and that might be on blood tests. So that bilirubin level might be very high, and we might see some abnormalities in the liver be able to produce clotting factors. That can sometimes be a bit difficult if you're on blood thinners already to interpret that. Or secondly, you might develop clinical complications, so develop fluid in the tummy called ascites. That can happen from the heart itself, and that's one of the challenges we have in assessing whether a liver transplant's needed or not. Is are there some of those complications coming from the heart directly, and the liver's actually okay, or are they a complication of the heart and the liver being cirrhotic that we see that. Liver cancer is also an indication for liver transplant. So it's a curative treatment for liver cancer in certain situations. And so that's another setting where we would recommend liver transplant. And secondly, there's certainly a possibility if someone who's undergoing a heart transplant, if we feel the liver's advanced enough that they won't get through the heart transplant without a liver transplant at the same time. So the livers are in bad enough shape that or good enough shape that they're getting through their life okay, but they won't get through the stress of a heart transplant, then we would recommend they have both done as well. And the last question is, an abstract from a recent medical article suggests there are increasing reports of combined heart-liver transplantation resulting from advanced liver disease. Do you have any information on the number of combined heart transplants that have been done internationally and in Australia and New Zealand? Any insights into the outcomes? I think I've answered that question overall, but yes, the reports of an increasing number of combined heart-liver transplants is true, and certainly in the US we're seeing much more. We're being faced with more people with Fontan-associated liver disease, and so it's certainly a watch this space type of condition where we're all observing the situation quite intently. I think also that, as mentioned, the expertise in liver transplantation and in heart transplantation and in combined procedures has increased both locally and internationally over time. But it is something that's never taken lightly. So if you are going down that pathway, it's something that's discussed extensively within transplant units at a multidisciplinary level. Often, we even seek second opinions from interstate or overseas in particularly complicated situations. And that's quite a common thing, as I mentioned in one of the earlier questions, that these communities of the transplant community, the congenital heart disease community, and the Fontan community in general are quite small and closely knit. So it's very easy to call on colleagues from other centres with similar interests for advice. So that brings us to a close for this question and answer session. I'm starting to get sick of my own voice, so thanks very much again for the opportunity, and I hope we can do this again soon. Thank you.